welcome to a broad range of people on the agenda tonight. I can see we're beaming as far and wide as Cairns, sexual health. So welcome to Erin. And there's some familiar faces on the screen too. So the agenda tonight, we've amended it slightly because we're going to have a presentation around OzCAPS, and my understanding was that was Sharon James, and I don't think she's in the room at the minute, and I can't see
Danielle.
Yeah, we see Danielle.
Maybe Danielle's going to do it.
Yeah, maybe Danielle. And I can't see Carolyn.
Okay, but well, she might be joining in a minute.
Yeah,
it's only 5 minutes.
Yeah. We usually kick off. We'll kick off with Carolyn, but
we could kick off with Danielle.
Danielle, and Danielle also said she's multitasking, but Danielle, oh no, she says she'll text Sharon James.
Oh, she'll text.
Okay.
Maybe we'll do Welcome to Country.
Yeah.
So good evening. Just while we're waiting for Sharon James to get online, we would normally welcome you all warmly and do a Welcome to Country. So although we're from far and wide this evening, from as far as Cairns to Mildura to down the coast a ways, I want to welcome you all, and I also want to acknowledge the traditional owners of the land in which I guess it's almost the majority of us are sitting or standing, the land of the Wurundjeri people of the Kulin Nation, and to mention that that land was never ceded, and that we have a clear and present and continued moral obligation to care for that land and the people who dwell on it. I also want to acknowledge elders past, present and emergent. And also to wish you all well and hope that you're all staying well and staying safe and staying sane at the moment. And I think it's great. We've got such a community of practice here tonight, isn't it, Kath?
Yeah.
Thanks the organisers for the opportunity to talk to you all about the OzCAPS community of practice, which we have just launched over the last week or so. Can you hear me all right? Yep, good. And so OzCAPS is a NHMRC funded partnerships grant, which has as its aim to improve access to long-acting reversible contraception and early medical abortion in primary care throughout Australia. So it's a national project. And the objective is to establish, implement and evaluate an innovative multidisciplinary online community of practice. And we are working really to emulate a very successful model that was run in Canada by our colleague, Dr. Wendy Norman, who's a family physician in Vancouver. And they found that an online community of practice was able to increase the number of providers of medical abortion in Canada and provide a lot of support for the implementation of it across primary care. So we've just kind of altered the model a little bit, because OzCAPS is actually going to be targeting GPs, practice nurses and pharmacists. And the rationale behind this is that it takes a multidisciplinary team to deliver high quality services. And we very much want dissemination of knowledge and implementation of skills across all the important players in primary care. So our partners on this project are the Department of Health in Canberra, the College of GPs, College of ONGs, Pharmacy Society, Australian Practice Nurse Association, Women's Health Nurses, Sexual Health Nurses, the Commission on Safety and Quality in Healthcare, who did an excellent project looking at variability of LARC, of IUD uptake across Australia in relation to heavy menstrual bleeding, but they're very interested in promoting appropriate and accessible IUD uptake. Our colleagues in family planning, Children by Choice, Jean Hales, Murray Stopes, Bayer, you name it, we've got them. And Paddy's involved in this project as a as the RANSCOG rep. So we're really drawing on the resources of all of our partners to successfully run this project. And this is what we are enrolling people into. So it's broadly based on a Facebook type model, and I think, you know, many of you will be involved in GP Down Under. The GPs might be involved in GP Down Under on Facebook and be in the MTOP Down Under group. But I would argue that the Facebook groups are closed groups and they are not multidisciplinary groups. And they don't have the capacity, I think, that AUSCAPS offers in terms of the integration with partners and partner organisations, and the capacity to really channel the participants in the online community of practice out to the relevant partners for the purposes of training or utilisation of resources. So what we're really trying to do here is not duplicate what others have done, but actually build on it and direct people through our online presence in AUSCAPS through to the network. Sarah Lim, you're on speaker. Can you mute, please? Thank you.
Sorry.
Thank you. So at the moment, we've been sending out recruitment notices across different networks, enrolling GPs, practice nurses and pharmacists to first undertake a survey, baseline survey of knowledge, attitudes and practices. And our target there is for 500 respondents in each of those target groups. And we've almost met those targets. And then we're also recruiting directly into the platform. And once you go through the steps of enrolment into the platform, you get onto this homepage. And then you're sent emails that give you updates about content when it's posted. And we're hoping to really build a strong conversation around various issues, get participants to post questions that our clinical experts will answer. And we have the support of our colleagues, Kathy McNamee and Deb Bateson, through family planning, assisting us with this. So there's chats, there's case studies. We'll be posting news and webinars and podcasts. We also have links through to training modules in various organisations, and we're working closely with SERSH, who are a sponsor of this initiative, using their modules, Murray Stopes modules, directing through to family planning. We have a resource library like patient information, checklists for GPs, nurses and pharmacists. What else? How to set up a practice in EMA, all manner of resources there. And we also have a database facility, the providers near you button that you can see there, that can form local networks by showing people who are providers and dispensers in primary health network regions. So this network will run for the next 2 or 3 years. We're going to be evaluating what content gets posted by participants. and evaluating the outcomes in terms of changes in EMA prescription and LARC prescription over the course of the project. And we're hoping that it really becomes a sustainable part of the landscape for primary care practitioners to really support them to deliver higher quality and more accessible services. So I'll stop there, and that's my presentation on the fly, unprepared. And I'll hand back to Kath and Paddy, and happy to take any questions.
So thanks for that. Before we open it out to other people's questions, there has been a discussion about, obviously you're very keen to recruit as many people into this community of practice, which then becomes a reiterative research engine and powerhouse, really. And the larger the numbers of recruitment, the more powerful it becomes.
Yes.
So there was talk about having just sort of like a one page or something that we could have on websites, or every time we give a talk, or any of the members here could
Yes.
spread the word. Have we got such a little bit of a
We
glossy?
do, and I can just see Sharon coming online now. Hi, Sharon.
Oh, right.
I've stolen the thunder and given the presentation, I'm afraid, a bit ad hoc. But
it's all right. I didn't get confirmation or a Zoom invite, so I didn't log on. But I'm very happy to answer any questions about AusCAP, so I can only apologise that I wasn't here earlier.
No worries. There's just a question about recruitment flyer and whether we could disseminate that through this network.
Absolutely. I was looking at that this afternoon, so that we should be able to turn that around very quickly for you. Yes.
So Sharon, you could communicate that to Joanna,
Joanna,
and then we could send that out as part of our post. I was going to say our post-operative communication, but obviously I'm a little bit confused with what I'm doing at the moment with our post get-together communication to everyone.
Yep.
Are there any other questions to either Daniela or Sharon about the project, how you can enroll, who it involves, what do we hope to get out of it? There's a question here from Caitlin. Curious, re the decision for terminology around women's access to long-acting reversible contraception, LARC, and medical abortion. Has consideration been made to being more inclusive for gender diverse people?
Yes, so that's a question that comes up with a lot of our work in Sphere. We use inclusive terminology in our written materials, and note that the term woman is inclusive of gender diverse people, and we make note of that in all of our publications. But we think it's also very important to use the word woman and not to drop that from the terminology when we talk about these kinds of issues, because many of our clients and consumers and patients identify themselves as women and like to see the word woman in the materials that they're given. So we try to be as inclusive as possible. Just one more issue I would like to stress is a lot of you on the line, I can see people who are clinicians who are involved in teaching other practitioners and mentoring other practitioners. And I want to stress that this site is for both current providers and anyone who's interested. So you don't have to be a provider or a dispenser to enroll in this site. What we're actually trying to do is get people onto the network who are interested, and then provide them with the support to become providers. So we're really hoping to also reach GP registrars and trainees throughout the disciplines that we're targeting, and to get them on board and to mentor them and support them with the network.
Just on that point, Danielle, I've actually enrolled to have a look
Right.
at the AUSCAP's website, but I did need to use my APRA number, and I'm aware that social workers don't have that form of regulation. So I'm just wondering if there's a way, and social workers have a role in terms of abortion care. I just wonder if there's a way of supporting people who don't have an APRA number to be enrolled.
Would you like me to answer that, Danielle?
Yeah, go ahead, Sharon.
So what those people can do, that question has come up again before, is that they can email the AUSCAP's team, and I will put the email address in the flyer, as well as in the chat, if that's helpful.
Okay, great. All right, because I'll let the team here know, and I'm aware of other social workers too. So thanks for that. We'll put that in the minutes as well.
Are there any
meeting notes?
Yeah, we'll certainly do that in the communique afterwards, Sharon. These are all really important questions. Are there other questions before we move on from this presentation?
Just before we do move on, I just wanted to say, Sharon, apologies for not confirming. That was clearly a misunderstanding, a miscommunication between us. So apologies to put you on the spot, and thanks, Danielle, for picking up.
Thank you. And I thought it was next week. Anyway, that's why I hadn't emailed you back. So I'm sorry.
Okay. That's all right. I think we're missing Kylie, actually.
We're all losing the plot.
Oh, no.
So if anybody also has any feedback or has any resources or knows of any materials that they think would be useful to put on the site that are not already on the site, please feel welcome to contact Sharon as the project manager to include those. We'd be delighted to get whatever you think is useful that's going to help deliver better, more accessible care.
Yeah.
We have a content plan that we plan for each day and each week and each month. So we're looking to make things interesting, but also contemporary. So please get in touch.
Well, yeah, I'll follow that up with you too, Sharon, because we've got a series of policy guideline procedures and another one just to come out in the next month or so around post-procedure care, post-early medical abortion care. So that could, and given that it's so difficult to access evidence-based guidelines around particularly the post-procedure care, that might be helpful too.
Thank you.
Just to elaborate on that, what we're finding that we get most questions about is not how to prescribe, how to find a pharmacist. It's about what to do with the person who comes back 10 days post-procedure with annoying bleeding. Is it retained products of conception? Is it endometritis? They're distressed. The provider who has prescribed the medication is distressed on their behalf as well, and how do we manage this? And this is what we're finding. I see some nods around the room. Is the art of MTOP provision. The easy part is the prescription. So we find a knowledge gap and a resource gap, and this is our suggestion to fill it. And we'll certainly share that with you. We've put it on all the other integrated websites that we're involved with.
Yeah.
Sorry, Danielle?
Thank you.
Yeah.
And these are all really good questions for people who are part of the community of practice to post to promote that discussion, so that expert clinicians such as Kathy and Deb can chime in as well if we need, but also to learn from each other.
Sure. Okay. Thanks so much to both of you for stepping up and on the spot. An apology from Carolyn. She's juggling her life at the moment, and she's got a medical emergency with one of her little human beings in her life, so she can't make it to tonight, and so we'll hold over the 1-800 My Options update to the next meeting. So Patty, I'm going to hand it over to you.
Should we share that?
Yeah, okay. We have have a discussion that came up just recently, and it's been an issue that's raised a couple of times, is around when to or how to manage
Iron
low
deficiency.
low iron and when to do iron studies. So I'll just share.
So I hope the screen is sharing. Could somebody just put a thumbs up? Oh yeah, thanks Kathy. You can never tell if it's sharing when you press the button. So look, this has come up in discussions and has been the source of voicemail queries and email queries quite consistently about when to treat iron deficiency, who we should be screening, who needs an iron transfusion, etc. So Mary Ann actually gave us a bit of a case history, which I have elaborated a little bit on, and hopefully that will promote. This is really not didactic. This is to promote some discussion. And if you can just give me an idea of the time count,
Sure.
so as we're progressing. So this is just introducing you to Aishuk, who is 19 years of age. She has had she's found out that she was pregnant by home pregnancy test. This is an unplanned and unwanted pregnancy. Aishuk is attending Teachers Training College, University by Zoom school at the moment, and she's very keen to terminate the pregnancy, and she comes to your rooms requesting a medical abortion. Now she's someone who you know several other members of her family, and you know that there is a strong history of iron deficiency anemia. So the question becomes whether or not she should be indeed investigated for it or treated for it. So just to cut to the chase, I was hoping to make this a bit interactive, but in the interests of time, I think we'll just press on. So it's important to take a discussion, to do a history and examination with regard to patients and whether or not they're symptomatic. So it would be important to know what her surgical and medical history, if anything, what medication she's on, and what family history she has. And what she returns is that her mother and her sister have both had a history of iron deficiency anemia. Her mother during her last 3 pregnancies, and her sister external to a pregnancy event when she had a procedure. And Aishuk herself, when she was 16, had an iron transfusion because she was symptomatic. Then it becomes important to find out if she's currently symptomatic, and the kind of questions we might ask her about tiredness, her exercise tolerance, postural symptoms, with of course the caveat that pregnancy symptoms and symptoms of iron deficiency have a huge Venn diagram overlap, and so it can be a bit difficult sometimes to tease those out. What are the clinical signs of anemia, to do some baseline observations, and to always think about doing a postural hypotension check, so standing and sitting blood pressure, checking her conjunctiva, and a general health check for her. Now, Marianne then included the investigations that she had done in terms of this patient, and she was symptomatic. So for the purposes of the presentation, she described poor exercise tolerance, breathlessness at rest, and she had pale conjunctiva. So, where's the investigations?
Oh, I didn't take them out.
You took them out?
No,
Yeah.
they're the investigations.
Oh, I just wanted. Yeah. Okay. Sorry. We just had I was just confused about how we were doing the presentation here. So if we just ignore the second half of the slide off to my right, so we do know that she had a hemoglobin done on the 1st of February 21, and that was a hemoglobin of 109. On the 28th of June, she'd had, this is during her first assessment, she had a hemoglobin of 104 and a iron of 2.3 with a transferrin of 3.6. And that was repeated on the 15th of July. The 15th of July was her assessment in the clinic by Marianne for the MTOP, and her hemoglobin was 106 with a low iron and transferrin of 4.10. So she was at that stage 5 weeks and 2 days. She had an ultrasound scan that indicated that it was an intrauterine pregnancy in that there was a yolk sac present, and the decision was made that she wished to proceed with the MTOP, and it was felt that she had good supports and that this was a really appropriate decision for her. However, the concern was about her low iron, and the decision was made to treat her with an iron transfusion, which was administered on the 26th of July prior to her having her early medical abortion. And then, just to see. Yeah, sorry, all I can see is a whole lot of faces. And on the 13th of August, her iron had improved. This is post MTOP. I'm not sure what her hemoglobin was at that point. But the discussion that comes up is, can I move that again? Yeah. What routine investigation should we do pre-early medical abortion? Who should we screen? Should we just screen those with a family history or demographic association? For example, our Indigenous communities, our refugee communities, those with a family history, and consider risk factors for anemia. And what should be our threshold for treatment? And so I had consulted some of my hematology friends, and also just got a basic literature review and looked at what Australian Prescriber was suggesting. And I wanted to just play devil's advocate here and suggest that when we're thinking about iron replacement therapy, it does take approximately 2 weeks before the patient would notice an increase in their hemoglobin, or indeed notice any symptomatic improvement. Now, treating someone with iron transfusion, while it's now more and more widespread, it's not completely without adverse outcomes, including allergic and anaphylactic responses, which are very low compared to what a blood transfusion used to be. But in the context of doing a lot of iron transfusions in this hospital, we've actually had one such event. And so you start to reconsider how you might think about iron supplementation. So the other point to make is that improving someone's iron stores doesn't change the course of the MTOP. And she was 5 weeks and 2 days at the point.
Anne, how are you?
All right, how are you?
Good, I'm just watching a webinar.
Sorry, somebody's not on mute.
Well, I'll let you go and you call me back when you're free.
No, I'll give you a couple of minutes, yeah. I'm back at work. I don't know whether you realise that.
Jane, could you mute your iPad?
Got a call from Joe Sunday to say...
Jane, are you able to mute your iPad? I could send her a message.
Anyway, back to me blethering on. So her MTOP presentation was at 5 weeks and 2 days. And what we do know about risk factors for heavy bleeding is that the earlier that we perform the MTOP, the earlier the patient experiences the MTOP, the less likely there are greater products of conception, so the less likely there is heavy bleeding. So I wanted to open that up for discussion. I also talked to hematologists who thought we were possibly erring too much on the side of caution by trying to do iron transfusions prior to MTOP, if the hemoglobin had not been below 100. That their level for treatment would be a hemoglobin of below 100, and certainly that would be our threshold if we were investigating someone before a surgical abortion. So this is not in any way a critical thought, Marianne, but just a thought about what are the machinations of this, and how are we improving or delaying access to an MTOP. The other thought was that perhaps ACHUC could have had oral supplementation, and that we think about iron as a secondary supplementation when either compliance or adherence to iron or side effects from iron precluded a woman from using it. And that may well have been ACHUC's past history. However, it did cause a delay in her accessing the medical abortion at home. And this is the reference that I wanted to draw your attention to, which I thought was very clear and concise. And just opening that up for any discussions. And Marianne, I know that we took the skeleton of your story and I played around with it a bit, but if you wanted to add or subtract anything or make any comments.
Stop sharing.
Yeah, thanks.
No, it was really just a question because I didn't know. So I just said to the person when they presented that I just have to check with the doctor, because I guess ultimately it's up to the person who's going to prescribe the medication. So I just said I'd have to check. And when I checked with the doctor, she said that that's the course of action she wanted to take. And I found it hard as the person who's, I guess, triaging in a way, to know. I had no kind of baseline as to, I didn't know at what point would you go, oh yes, we better check this one out first or not. I wasn't sure. So that's why I wanted this discussed, to learn from it.
So from a triage point of view, how would you react to that? If there's somebody with a very strong family history, and ACHUC had a personal history, I believe too, that a baseline hemoglobin with the ferritin studies is useful, and hers was over 100. So thinking of just oral supplementation while she goes ahead with her MTOP, and if she runs into trouble with that, then she can always have the iron transfusion down the line.
Yeah, okay. So if the hemoglobin's under 100 and no actual with the ferritin, so her ferritin was below 2, I think.
Yeah, it was below,
Oh, 2, yeah. So no, that doesn't come into it. Like when you're talking about that study or who you spoke to, they said if it's, as long as it's over 100, they wouldn't think about it at that point in time. But the ferritin doesn't.
No. So the blood loss at a MTOP, what she's losing is heme, and it takes 2 weeks anyway to build that up.
Yeah.
And having your iron stores adequate is not going to prevent you bleeding.
Right. Yeah. Okay.
Yeah. So that's the point. Yeah. So and I know that we do a lot of identification of iron deficiency in the community, and that's important, and we know that women in particular in Australia have really high incidences of iron deficiency, but does it preclude them from having an MTOP per se? And I'm just advocating that we think about when it's the blood loss that we want to control.
Oh,
and so there's another way of looking at it. Because at 7 weeks, we do know that, the blood loss is probably going to be
greater.
More.
Yeah. No, that's good. That's what I wanted to. I wanted to find out. Yeah.
I'm just wondering what other people thought. That's my take on it, because in the surgical world, we hardly ever do a hemoglobin for our surgical terminations, unless they're really truly they're truly symptomatic.
A hemoglobin or an iron study?
Either.
Yeah.
I mean, we're coming from a somewhat different one-stop shop, not seeing them again, which is somewhat different from the much more holistic care that primary care give, and so you probably have more access to iron studies, etc. You may have had a previous history of iron. Of iron deficiency. We don't necessarily know all of that when a patient's referred. So it may not have generated it. But because we have tighter control of blood loss, one might think, at the time of surgical procedures, you might understand that we might not do hemoglobins and iron studies on everyone, particularly when we're doing same-day services as well. But it's just worth thinking about that in terms of, you know, over-medicalizing, maybe, you know, the MTOP procedure. Yeah. When we know how safe it is in countries, how safely distributed it has been in low resource settings where they don't have access to this.
Just a little add-on to it, Patty, is what would have been the outcome if she had the iron infusion and then decided to continue the pregnancy? I mean, I know it's not recommended, but...
So do you think that might, what in particular are you talking about, teratogenicity or something?
Yeah. Because it's not usually recommended, is it? No,
there'd be no problem.
Yeah.
Sorry, Kathy's waving. Hi, Kathy.
Patty, sorry, I wasn't clear, but was the MTOP delayed to have the iron infusion, or was that
that's the way we were? Yeah, that's the way we were playing that vignette. Yeah.
But if you're just sort of thinking like you want to build up her iron in general, you know, because I must say, having had an iron transfusion, I felt $1 million after it, and my hemoglobin wasn't that low, so it'd be fine just to sort of give it to her as a general principle, but just do the MTOP. Like straight away.
So no, I was in no way suggesting we did not supplement this young woman's iron.
Yeah.
She's clearly iron deficient. She's at risk.
Yeah.
She's probably got a malabsorptive genetic pool, something like that. She may have poor nutrition. She's been anemic before. We're going to have to supplement her.
Yeah.
It's just, do you have to delay this young woman's MTOP? She's in front of you today.
Yeah.
She's 19 years of age.
Yeah.
She's there. You've got her right there.
Yeah.
Does she really have to come back again? And this young woman obviously did, and that was fine.
Yeah.
But it's just to think around that you know, it's not certainly mandated that we do treat their iron levels.
Yeah.
But if someone's symptomatically anemic, then we really do need to look at that being a contraindication. Does anyone else have any comments or any experience around this? Samantha.
Yeah, hi. We've had a few recently, which kind of we haven't had that many overall, but recently we have, and it has come up about iron transfusions. And then I think, you know, same thing. At the end of the day, it's up to the GP. They're the ones prescribing. So it is passed by the GP. And I find that they all have a different take.
Everybody does, yeah.
They do, yeah. So I think it is, definitely, you know, we get their full history. And it may be even flagged before we do their bloods that they've had issues with, you know, iron in the past and heavy bleeding and things like that. So I guess, we've started having more conversations around. I think one was we didn't have her blood results, but she said she's always had lower iron. So the doctor did recommend that she follow up with her own GP to organise that, which she was not fussed about because she's done it in the past. So she did have one before we could see her again anyway. And I think another one was we're waiting to hear, actually, because her GP wouldn't organise one. So our tendency is that our GPs send them back to their own GPs for things like that, and then they come back to us. But as I said, there's only been, I think, 3 that I've dealt with, and they've all been dealt with very differently.
And so, Samantha, I'm picking up that you're a service that other GPs refer to for MTOP.
Yes.
Whereas they would look after other things for their patient group.
Yeah, that's right.
So that's you know, a specific kind of primary care delivery, whereas in other primary care delivery methodologies, that patient is a patient of the practice.
Yep.
Yeah. And you can imagine that there would be different, that would be different again from Kathy arranging something through family planning Victoria or me sitting here in Parkville seeing the patient for one occasion and she's going to have follow-up. Yeah.
Yes. Yep. Yep. But yeah, it has
We just
been
need to
interesting.
acknowledge that, you know, different physicians, you know, these are guidelines. The TGA mandates a few key things. It doesn't actually mandate this at all and doesn't regard iron deficiency as a contraindication. It's a bit like high blood pressure. It's a relative contraindication. But so different practitioners will have different thoughts on this, but also different prescription methodologies and service delivery modes will of necessity think about this differently. Because are you the only, you know, are you the only service that's going to see them, or have they got other service providers?
And we do FBE and HB and iron studies on everyone, just routinely.
Right. Does everybody do that? We could do a straw poll on this.
Interestingly, we don't do them,
No.
Patty. It's just they're the results that got sent to us with their referral. We hadn't seen it before either.
Right. Yeah.
We just got the referral, and that's what they'd requested.
So just to clarify, you don't do FBE routinely?
Oh, we do FBE, but we don't
FBE
do iron studies. Yeah.
You don't do that routinely. Yeah. And nor do we, but we do get quite a lot of investigations sent with the patient.
Yeah, that's the same with me. We get a lot of referrals with it already done the HB and yeah. But I am seeing a lot of anemia.
Yeah.
Not as severe as that, but really low iron stores and things. It's amazing.
Someone asked a question there. Can you do that?
Oh, so this is an interesting question. Sorry, from Erin McBride. I do acknowledge that it's hard to interact with you guys face to face here, and then the chat on the side. So if I miss a chat, just chat again and say hi. You missed me. So Erin McBride from Queensland. Yes. No.
I'm not sure.
No.
It's not.
It's Erin Kelly from Queensland. Sorry. Can a stop be considered safer than an MTOP in a case of an iron deficiency anemia? Yes. You know, if they're, and again, I'm using this 100 hemoglobin of 100 or less. If someone is symptomatically anemic or they've got a starting hemoglobin of 100, then that is a contraindication for MTOP if they're really symptomatic, and that would be a reason why we would do it. Because, as I said before, when we're doing a surgical abortion, the whole assumption is that we have acute control of blood loss. We've got an anaesthetist, we've got syntocinon, you know, we've got vasopressive agents right there. So it could be, yeah. And so we have, you know, we routinely, like you, Siobhan, we are seeing in the refugee and Indigenous and Pacifica population hemoglobins, entry hemoglobins of 80, 70, that sort of thing. And what we will do is we'll do the procedure, and immediately in recovery they get their iron transfusion. Because our outpatients clinic won't do it, but our recovery nurses will. So it doesn't really matter at which point we do it. It's just that we want to supplement their iron. And then there was another question. Our local hospital organises an iron transfusion for people with a hemoglobin under 100. And then someone else said, someone else said that they routinely do a hemoglobin on everyone before their MTOP, yeah. But it doesn't sound like everybody's doing iron routinely of these, you know, secondary primary care providers, yeah. Any further comments? Oh, yes, sorry. Hello, Sarah.
Hi, Patty. I had a question, and Mary Ann asked about the lady, if she's had an iron infusion and continued with her pregnancy, said that's safe. So I had a patient who is already iron deficient pre-pregnancy. She can't tolerate iron tablets, and she fell pregnant. Her ferritin's 6, and her hemoglobin is 105, I believe. She's in her first trimester, and we discussed, you know, trying oral tablets again, and that made her really nauseated. She wasn't keen on iron transfusion because she heard that it's not safe in first trimester. But I was just wondering, she's quite symptomatic, so she's very tired. She's not feeling very well. Would you consider iron transfusion in that case, or would you say hang on till sort of third trimester?
So this is a patient who's continuing her pregnancy.
Yeah.
Sarah, I have to say that this is no longer my area of expertise.
That's all right.
My life and clinical expertise has gone in the other direction, and so I would be asking one of my obstetric colleagues, or is she linked into antenatal care? Is she shared care?
Yeah, shared care.
Yes, so I would be asking the team, for their opinion, because again, I don't want to talk out of turn, but there will be different opinions on this depending on where her antenatal care is provided.
Yeah, sounds good. Thank you.
But it's so common that people hate iron tablets. They're not nice, are they? What about dietary supplementation? That's also needs to be. But meat. Yeah. Speaking as a vegetarian, I recommend meat eating for very low iron in pregnancy. Always did.
Liquid nitrogen.
Liquid nitrogen's fantastic for boys, Siobhan.
Liquid iron in your orange juice because it tastes like drinking nails. But liquid iron is often more tolerated than the tablet.
Yeah. And I guess it's also useful to check what tablets your patients are taking, because they'll often say, I'm on the iron, it's not doing anything, and you discover they're on some homeopathic dose of iron.
And also, are they having their tablets first thing in the morning with their first cup of coffee or tea? Because that'll stop the absorption with the, Yeah, so with the orange juice, nothing else.
Okay, have we chewed this one enough? I think so, maybe. Yeah, very interesting. And thank you, Marianne. These are the sort of things that, just a little question, we can turn it into, quite a discussion, and you discover that these are the sort of things that, you're having to ask advice for on a regular basis.
Sorry. So, I just ask one more thing. If someone was sort of in the high 9s in terms of their hemoglobin.
Sorry, Kathy, could you say that again?
Oh, sorry. If someone was sort of in their high 9s in terms of their hemoglobin and they were feeling well, would you consider a medical termination?
If they were in the high 9?
Yeah. For their
feeling
hemoglobin.
Well?
Yeah, feeling well. Yeah.
Yeah, but it's a contraindication, and you need to discuss it with them, and they need to be aware, and they need to be aware of when they would seek help. Yeah. I guess the more I do, the less hard lines I have.
Yeah.
And the less worry you have, Okay.
Do we go around the traps, see if anyone's got anything?
Yeah, so just in the last few minutes, just in the last few minutes, one of the things that I have pledged to bring up at every meeting is just a reminder to folk that the guidelines with regard to rhesus D immunoglobulin and anti-D administration have changed, and the National Blood Authority guidelines are very clear now that for medical termination of pregnancy under 9 weeks, we are not required to administer anti-D, which was just another hurdle falling over fantastically for our patients. And just to remind everybody, we'll send out that link as well, because that's the other question I get asked all the time, is where can I send my patient for anti-D? And my answer now is you don't have to. So if we just went round the traps as we talk about it, anyone who wants to say anything from where they're working, either about the experience at the moment, during COVID, how COVID is affecting their practice, how it's affecting their practitioners, or any changes in their service development that they'd like to share with us, or any questions at all, please feel free to make a comment. Or Samantha.
All right. Yeah, just today I work across 2 sites, Wodonga and Wangaratta, and with this lockdown, again, I'm not allowed to go across both sites. So, we've got bubbles, so I'm in Wangaratta. We organise surgical terminations, and it is paper-based with the hospital. So, there's lots of issues. And it was just introduced again on Monday with the hospitals that the patients have to have a COVID test and then isolate until their surgery.
I know. I feel your pain. We have to do the same thing here. And vaccination status is irrelevant. Everybody has to be treated like the imminent threat that they are, and we're doing it again. And it's yet another barrier. But unlike last year, and I suppose this is me trying to turn your comment around and just be a little bit more positive. Unlike last year, we've got great community testing. Mm-hmm. And so we're still able to offer same-day services here because our patients are getting almost a 24-hour turnaround in their community testing, which is better than the hospital testing, which is 48 hours. So we're lucky. We're not demanding they come for their test. We're telling them to go to the community tests. Yeah.
Right. Yep. I think today, the hospital were just on the back foot as well. So today I had 2 people that travelled from other areas to me, and then our testing place closes at 3 p.m. And so I had someone after that who I ended up getting to come in the lunch, in my lunch break to get her organised. So it was just really being aware. I think now that we've kind of, we know that that's happening, it's much easier to deal with. Just the last couple of days has been a bit messy just around that. So it's just people being aware.
Yeah, it's that transitioning from one set of rules to the next set of rules and then back again twice in a week is quite complicated, and we just have to continue being really flexible, don't we?
Yeah.
Erin, did you have a comment to make, Del?
Sorry, was that Erin Kelly in Mildura?
Yeah.
Yeah, hi.
Hi, Erin Kelly. How are you going up there?
Yeah, not too bad. I did post some information, a link to the Royal Women's patient information on iron infusions, and again, safe in 2nd and 3rd trimester. I suppose just to comment what I'm seeing.
Thanks for that, Erin. I should be familiar with that. It's my hospital.
I suppose, unfortunately, what I'm seeing in some of my community clinics is, later presentations, diagnosis of pregnancies mid-trimester or even at 20 weeks, and unfortunately more teenage pregnancies with my Indigenous community. Fortunately, in my outreach clinic in Robinvale, I think the introduction of free condoms in the caravan park and, less multicultural or transient people, that's helped the numbers be low there. But just complex trying to coordinate mid-trimester losses and getting clients down to Melbourne. So thank you for your help with those cases.
It's full on, isn't it? And what do you think the main reason for delay is? Is it people not being able to get a scan earlier, or is it part of, we're just musing on, even in urban Melbourne, that we're seeing this really big increase in later gestational age presentations?
Yeah, I think unfortunately it's a combination of all factors, a little bit of fear and anxiety trying to come in for certain communities, but then also the difficulty in seeing the GPs for getting investigations for diagnosis early, less GP face-to-face, not being asked certain questions or delving deeper into their clinical presentation, and just missing, unfortunately, these cases on the phone.
I think it's all of those things. We've just had a really good question. I'm sure it's Elizabeth up in Shepparton. I think she's in quarantine, working from home. Is it you, Elizabeth? Oh dear.
Yes, it's me. It's me.
You've not done a telephone or telemedicine MTOP, has anyone? Yes. How do you get consent signed? Look, it's not mandatory to get it the consent signed, you can document that you obtained full consent over the phone and that the patient demonstrated that. And it is not mandated by the TGA that you need signed consent for this.
Okay, thank you.
And also, Elizabeth, we did a whole session through this network on consent and just, being flexible in your service delivery in the context of COVID. So I can send you the notes to that meeting, but you can also see it on the SERSH resource hub under this network meeting minutes. Not so much minutes, actually. They're meeting notes, and there's even a recording of it as well.
Okay, thank you.
If you put your email in the chat, I can send it to you directly. But I'd encourage you to have a look at the resource hub as well, the SERSH resource hub.
If you're looking at doing it by telemedicine, there are some really creative ways, and someone such as Mark Farrugia shared a shared care methodology that he had with nurses obtaining consent elsewhere and faxing it to him, etc. So, there are ways around this. Yeah, and so we're happy to talk to you further about that.
And I know family plan, Kathy McNamee is just commenting in the chat too.
And so Kathy's saying we send them a text with a link to the consent form. So that's the MS2 step consent form or your own consent form?
Our own, yeah.
Sorry?
Our own one, yeah.
Your own one. So you could develop your own one and send a link so that they could download it. And they can look at it while you're going through it. Either way, yeah.
On the in the SERSH online modules, Elizabeth, which you know well, in the MTOP service delivery one, there's a resource section, and that has different copies of different places' consent forms, and you could use that and email it. That's the sort of thing that we do in CoHealth and Laverton. Yeah, and if you wanted a set of those documents that we email, I could get them to you from Madeline, the nurse who runs our clinic.
Great. And I'm just going to close with a reflection that this is the great thing about this network is that there are as many solutions as there are communities in Victoria and across Australia. We're all coming up with different ways of getting around the obstacles and problems that we're seeing for our patients. So I'm going to close by thanking you all for that, and just to reflect that I always come to these meetings at the end of the day somewhat tired, fatigued, and at times somewhat more jaded about the situation we're in than others, and I leave them feeling energized. Don't know about you, Kat.
Yeah, that's good.
Yeah, I leave them feeling energized. So this is what a community of practice should be doing. All power to us.
Yeah.
You're great. Lovely to see you all and to hear you all. Till we meet again. Time for a G&T, someone said. Thank you, Kathy.
No worries. You deserve it.
Only Tuesday night. Bye for now.